There's a really amazing concept developed by Dr. Ellie Lett talking about health equity tourism, which basically talks about like how many researchers racialize themselves, and also white researchers come and parachute within communities and do health equity tourism. And we've seen this like with the intensification of certain grants that have popped up that focus on doing research on racialized communities, right? And there's four components to that Dr. Lepp mentions in talking about health equity tourism. One is that equity is fundamental. So a community member framework is one that views equity as fundamental goals of its all scientific inquiry related to health, as opposed to an enterprise only tangentially related to their core research agenda. And this has two questions posed. Who is represented in the study? For example, the reliance on statistically significant findings to determine the importance for our work generates an environment where the largest groups are regarded as the most important, right? And then question number two within that principle is like, how can this work cause harm? Historically, much research has worked on populations rather than with, right? And number two is positionality as healthcare praxis, which I think is really, really important and like encouraging reflexivity too, right? So dynamic health equity research engages an epistemological lens that is intrinsically tied to the researcher and bears an often overlooked nexus. Who are you impacts the kind of science that you do, right? And number three is collaboration. And just as no single discipline independently handles all aspects of patient care, a research team concerning health equity and health equity should include a transdisciplinary assortment of professionals. And lastly, number four, sustainability and urgency. When tourists enter a space with an emphasis on quick action, mistakes are often made. The reality is many of the observed inequities are longstanding or acute shocks to an already unjust system, like for example, COVID-19. In truth, few studies have immediate impacts on health equity and often become part of a cumulative evidence that are base used to motivate policy changes. There are no research emergencies, and such expediency can result in deficit-based science that pathologizes communities rather than redistributing power and resources.